The visceral support for the posterior vaginal wall depends upon the intact rectovaginal fascia, which is responsible for the more horizontal orientation of the upper two-thirds of the vagina over the muscular levator plate. The rectovaginal fascia is located in the rectovaginal space and underneath the posterior vaginal epithelium. This layer supports the upper vagina from the apex of the perineal body, laterally along the iliococcygeus muscles and posteriorly to the uterosacral ligaments and cul-de-sac peritoneum. The rectovaginal fascia continues to the level of the ischial spines and thus overlies the sacrospinous ligaments. The perineal body is shaped like a pyramid, with the square base between the anus and vaginal introitus. Its height is 3 to 4 centimeters, with the apex located between the lower third and middle third of the posterior vaginal wall. The levator plate is the tendinous support formed by the fusion in the midline between the rectoanal junction and the coccyx of the levator ani muscles, pubococcygeus, puborectalis, and iliococcygeus. It is approximately 4 centimeters long and establishes a strong, dynamic platform against which the upper vagina and rectum are compressed during valsalva stress in order to prevent vaginal prolapse. Inferior or below the levator ani muscles on each side is the ischioanal fossa. This area is filled with fatty areolar tissue and bounded laterally by the obturator internus muscle, medially by the rectum and anal canal, posteriorly by the sacrotuberous ligament, and inferiorly by the skin of the buttocks. The pudendal nerve and internal pudendal vessels are located along the side wall of the obturator internus muscle in the pudendal or alcox canal. The pudendal nerve and vessels give rise to the inferior rectal or hemorrhoidal branches, which traverse across the ischioanal fossa to service the anal canal, sphincter ani muscle, and anus. Gynacare Gynemesh PS is a soft, pliable polypropylene material intended to reinforce weakened rectovaginal fascia and visceral connective tissues that surround the vaginal epithelium in the patient with pelvic floor prolapse. The mesh is pre-cut to form a supporting core implant with attachment arms. With the need to repair a posterior vaginal wall prolapse with Gynacare Gynemesh PS, the mesh is placed in the true rectovaginal space between the rectal muscularis and the fibromuscular coat surrounding the posterior vaginal epithelium. This restores the support of the rectovaginal fascia from the apex of the perineal body to the uterosacral ligaments at the level of the ischial spines. The apex of the perineal body is located at the junction of the lower third of the vagina with the middle third. During the posterior placement of the Gynacare Gynemesh PS in the Gynacare ProLift pelvic floor repair system procedure, there is one strap of mesh that passes through the ischioanal fossa, one through each side. The instrument and mesh strap pass below the levator ani muscles and course to and through the mid-portion of the sacrospinous ligament. This passage allows for the placement of the Gynacare Gynemesh PS in the already dissected rectovaginal space, which is found above the levator ani muscles. The rectovaginal space is easily developed surgically by incising the lower half of the posterior vaginal epithelium, full thickness, and opening the space with the finger. The finger dissection extends pararectally back to the ischial spines and sacrospinous ligaments. A 4 mm incision is placed in the skin of the buttock in relation to the anus, 3 cm below and 3 cm lateral. The cannula-equipped guide is placed with firm hand control through the incision and passed towards the sacrospinous ligament, staying well away from the pelvic sidewall. The surgeon's finger in the dissected rectovaginal space is on the superior side of the levator ani muscles, whereby he or she can feel and direct the cannula-equipped guide passing on the underside of the levator ani muscles in the ischio-anal fossa. The cannula-equipped guide passes through the subcutaneous tissues, then the dense fat of the ischio-anal fossa to the underside of the sacrospinous ligament, approximately 2 cm medial to the ischial spine. The cannula-equipped guide perforates the mid-portion of the sacrospinous ligament and enters the rectovaginal space. With the cannula held in place, the guide is carefully removed, and the retrieval device is passed through the cannula. The retrieval device is retrieved from the rectovaginal space and affixed outside the vagina on the surgical drape. In this space are the inferior rectal nerves and vessels coursing medially from the pudendal nerve and inferior pudendal vessels in the pudendal or Alcock's canal. The pudendal canal is located in the fascia of the obturator internus muscle, the lateral boundary of the ischio-anal fossa. More posteriorly, these pudendal structures course within 2 cm of the ischial spine, underneath the sacrospinous ligament. The passage must also remain in the substance of the mid-portion of the sacrospinous ligament, since the inferior gluteal nerve and vessels pass over its upper posterior edge. The retrieval device guides the mesh strap back through the sacrospinous ligament, through the ischio-anal fossa, and out through the skin of the buttock.